All right, so we've got a great number of participants already joined. So why don't we start to kick things off? Before we do begin, I do want to go over our U of T land acknowledgement. And so, of course, we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. And just a bit about T-CAIREM. The T-CAIREM Center for AI Research and Education in Medicine at the University of Toronto has been made possible by the real generous donation of the Temerty family. So we're really appreciative of that. T-CAIREM is an interdepartmental center that serves as a focal point for collaboration among healthcare providers, among trainees, researchers, computer scientists, engineers, and even industry. And truly, our goal at T-CAIREM is to transform health through AI. I also want to make a quick mention that this event is a CPD accredited event, which is awesome. So at the end, you'll see a survey link that comes in through the chat, and there might be a QR code that comes up on the screen potentially. If so, please fill out the survey and the evaluation form, and make sure to add your name and email address to that form so you can get your CPD credits. And so now on to the main event. We've got an incredible speaker here with a lot of real world experience, and I'm really honored to be able to introduce Dr. Karandeep Singh. Dr. Karandeep Singh has recently been hired as an incoming faculty member, Chief Health AI Officer, and Associate Chief Medical Information Officer for the Inpatient Care unit at UC San Diego Health. So incredible roles, super jealous that you're going to be living in San Diego. So we'll have to find an excuse to come out and meet you, Dr. Singh. Prior to this role, he was an associate professor of learning health sciences, internal medicine, neurology, and information at the University of Michigan. He also directed the Machine Learning for Learning Health Systems Lab, which focused on translational issues related to the implementation of machine learning models within health systems. And so in this talk, Dr. Singh is going to talk about real-world examples to illustrate common implementation roadblocks that can lead AI models to fail. And so what a great opportunity for us to learn from your past experience. And without further ado, Dr. Singh, take it away.
Thank you so much, Devin. Let me go ahead and just get my slides on here. Okay, I'm just waiting for them to load. So thank you again for the opportunity to present to T-CAIREM and the community around T-CAIREM. As I told you privately ahead of time, Toronto is a special place in my heart. I actually got married in Toronto, have a family members in Toronto, so we make a couple of trips out there every year. Looking forward to, as I welcome you over to UC San Diego, also hopefully connecting when I'm in town in Toronto. So today I'll be talking about a topic that I unfortunately have some experience with, which is around failure in implementing health AI. And I wanted to talk through some of the key challenges that come up around why health AI is difficult to implement, and just share some of my thinking around ways we can try to anticipate these failures and overcome them. Here are some disclosures around current grant funding and some prior grant funding and consulting experience. The objectives today really are to talk about what makes an ideal AI implementation, and then focus on two components of AI implementations that I think both contribute to failure separately. One of them is the actual models themselves that we're implementing into a workflow, and the second one is with the actual workflows. And then I'll kind of step back and just think about what are some things that the community is trying to do as a whole to try to make AI better and safer as we try to get AI implementations off the ground. So I think it's a useful place to start is the AI paradox in health. And in my mind, what the AI paradox in health is that researched AI tools aren't implemented and implemented AI tools aren't researched. And so what happens is if you're a researcher in this space and you're looking at the literature, you start to look at the literature and you see a lot of literature describing the development of AI tools, lesser literature or fewer papers describing validation, even fewer papers describing implementation, and even fewer papers describing the actual usage or adoption of these AI tools in practice. And so you might come away with the impression that there's just not a lot of stuff being implemented. because if you look at the literature, so much of the literature is focused on development and not on implementation. But on the flip side, if you look at what's actually implemented, there are so many tools that are available from, everything from established companies to startups, from big tech to health specific companies, to things being developed and marketed through other arrangements where researchers are spinning off, companies. And so if you're in the implementation space, you just see all these things coming at you, and they're essentially coming at you in the form of PowerPoint decks. And so ultimately, there is this paradox that, on one hand, the research is not around implementation, and the tools that are actually available to implement often aren't very well researched. And so that's where I like to have this kind of visual of, yes, there's this drop in the bucket that's coming from the research pipeline of very carefully thought out tools that are being implemented. And there's definitely some of these tools out there. So I think it's, really laudable to see tools like this that come from the research pipeline and get implemented. But there's this flood of tools that are available from industry, some of which are carefully evaluated, but not in the open kind of public literature. And so you have to do a lot of evaluation yourself to decide if you kind of believe what's being put forward out of various commercial vendors and industry. And that's where I think that mismatch is between what's coming out of research and what's really happening on the ground if you're someone like a chief medical information officer in the position of trying to implement these tools. So what do I mean by AI implementation? I think most folks in the audience probably have a good idea of what I mean, but it's nice to just talk about this at a very high level. So when I say AI implementation, I really just am referring to an AI model that produces a recommendation that's reviewed by a person, often a clinician or someone on staff as part of some kind of business workflow, and that ultimately this recommendation is implemented into a clinical workflow. Even this is a bit of an oversimplification because models don't always produce recommendations. Sometimes models produce risk scores, and then we apply guidelines to turn those risk scores into recommendations. But you get the idea that this is one common human-in-the-loop way of implementing AI. It's not the only way. There's probably dozens of ways, but I'll share one variation on that, which is an AI model that produces a recommendation that's actually implemented into a clinical workflow, and that workflow reorganizes or streamlines a person's work. So as an example of this, if you have an algorithm that can predict the risk of stroke, you might use that algorithm to actually alert a radiologist when there is a potential stroke detected, so the radiologist can drop what they're doing to look at that image. On the other hand, though, you could reorganize their work. So you don't actually interrupt them, but when they have an order of tests that they're going to read, the next test that is on their list is the one that has the highest risk of stroke. And so in essence, you've reorganized or streamlined their work, even though it's kind of happening invisibly and in an non-interruptive way. So both of those are examples of ways in which you might use AI-based information to drive a clinical workflow. So before we talk about how models fail, it's useful to talk about what does an ideal AI implementation look like. So I would say broadly, an ideal AI implementation is one that produces recommendations that are informative, that we can act on, that it allocates time better for people. So a lot of these algorithms are essentially, producing risk scores for various outcomes that are ultimately driving how we reprioritize our time, and therefore we want to make sure we're allocating time more effectively. And ideally, we allocate more resources towards the people who may benefit from them, and that there's some recognition of the role of equity and how we actually reorganize what we do, so that maybe we can't do more, but what we do is done in a more equitable and kind of effective way. So broadly, if we think about why AI implementations fail, there's a handful of issues that I'll highlight around AI models and the recommendations they produce that I think contribute to failure. And then there are some issues related to the actual workflow, how care gets reorganized and reallocated, that I think contributes to failure. So we'll hone in on these. And I think recognizing that, I want to wrap up a little bit early so we have time for questions, I may skip around a little bit and, spend more time on some of these than others. Okay, so let's first talk about why do the actual models themselves fail? And I would say if you look at, the root cause of failure for a lot of these algorithms, a lot of these boil down into lack of transparency, lack of reproducibility, lack of transportability, The fact that it's possible for a model to produce a recommendation that if you were to act on it would result in an outcome that's worse than not having a model at all, I think is something we often fail to acknowledge. And then this idea of modifiable risk versus non-modifiable risk and some issues that come up around that. So I'll start with kind of just a story around some of our work and looking at a sepsis model to highlight how these issues all can be kind of separately looked at, but in many ways they are connected and intertwined. So a couple of years back, during my time at the University of Michigan, we had looked at the implementation of a vendor-developed sepsis model among our hospitalized patients to try to independently evaluate how well this model was performing. We had been running this model silently for several years, and in 2 or 3 of our inpatient units, we actually were starting to pilot a clinical workflow around it, and finding that, that piloting this clinical workflow wasn't really producing substantial benefits in terms of our quality measures. We decided to take a step back and look at, how was this model interplaying with our ability to detect sepsis and to act on sepsis. So looking at the sepsis model, the model brief that we got from Epic was marked as kind of proprietary confidential. And so as we were doing this evaluation and writing it up, we actually asked Epic for permission to include parts of that model brief in our paper as a supplement. And so this is the snippet from that model brief that we kind of copy pasted out with permission and included in our paper. And if you look at what goes into the sepsis model, a lot of it is very reasonable stuff. It includes things like vital signs, medication orders, lab values, comorbidities, some demographic information. And when you look at this model, which is trained and evaluated at 3 different organizations, it produces a error under the curve for the prediction of sepsis of somewhere between 0.76 and 0.83. So I think many folks on the call may know, kind of what that means, but I won't dig into it too much other than to say that, closer to 1 is great. And if you ask most CMIOs, what's a good error in the curve, the answer you'll get is 0.8. And so I'm not saying I subscribe to that thinking. I think it actually depends on the different use case. But for the purposes of, our evaluating it and having this information, this looked like something that was reasonable enough for us to try to use to predict sepsis among our patients. So a couple of different issues pop up here. In the initial model brief that we got, even from Epic that was confidential and proprietary, even that kind of a model brief can have a lot of missing information. This is actually a paper from Jonathan Liu and Nigam Shah's group at Stanford that looked at the adherence to reporting guidelines across Epic model briefs. And I say Epic model briefs not with any kind of negative thinking towards Epic. I would say Epic is probably ahead of the curve. And so any numbers you see here, probably you can assume on average worse numbers for others, vendors in this space. But even looking at, the percent completeness for the sepsis guideline or for the sepsis model, only about half to maybe, 2/3 of the items that you would expect to see in that model brief based on kind of common reporting guidelines are there. So that's what I'm showing here with that highlighted column. About 40 to 70% of the items are there. And probably the most commonly used reporting guideline in my space is the tripod guideline. And so even on the tripod guidelines, just over half, nearly 2/3 of the items that you would expect to see are there. So already, even if you have the information, directly from the vendor who's developed the model, you may have to go back to them because that information may not be complete. The second issue was this issue of reproducibility. And so when we tried to reproduce the evaluation using the sepsis definition that our hospital used as part of its operational decision-making, we found that the model could predict the onset of sepsis with an error under the curve of 0.63, which is lower than that 0.76 to 0.8 range or 0.83 range that we were talking about, was reported by the vendor. And that's substantially lower. If you look at the ability of the model to predict sepsis in the couple of hours after sepsis actually took place, the model does much better. The error in the curve is 0.8, which is much more close to what Epic was reporting in its model brief. Now, there's certainly reasons why we want to be able to identify sepsis even in the handful of hours after it's occurred, because there are still parts of our sepsis bundle actions we might want to take that are relevant. I highlight these differences here mainly to show you that the vendor was suggesting that the model predicts sepsis before its onset, but when we really tried to dig into that, we found that it does a much better job of predicting sepsis after sepsis has occurred and not before its onset. So is this a reproducibility issue? The reason I say it's a reproducibility issue is that when we looked at the area under the curve on our data, we got this measurement of 0.63. When we actually asked the vendor to look at and calculate the area under the curve, again, on our data, not the exact same data set I used here, but very similar, contemporaneous data, they reported the area under the curve was 0.88. So already there's a huge discrepancy in what we're measuring. And a lot of that has to do with how we define the outcome. But, already if we're using it to drive decision-making for our sepsis committee, what actually ends up mattering to the sepsis committee is what the operational definition of sepsis that they're using, and not necessarily the definition that was used to train the model and evaluate it from the vendor's perspective. So we talked about transparency, we talked about reproducibility. Another related issue is transportability. So one of the arguments would be that just because a model works in one place doesn't mean it's going to work elsewhere. And the reason we see this happen a lot in machine learning is that many of the models we use have practice patterns either as outcomes or practice patterns as predictors. And when practice patterns differ across places, you wouldn't even expect a model that works in one place to necessarily work into another if one of the key things driving its prediction is the actual local practice pattern. So our evaluation at Michigan was kind of a single center evaluation. So we said, okay, obviously that has to be taken with a grain of salt because it's one place. So I partnered up with colleagues at WashU, Philip Payne, Patrick Lyons, and we said, let's try to redo this evaluation across a network of 9 hospitals in your health setting. And what we found, if you focus just on the y-axis here, is there are places that have an area under the curve close to 0.75, where it's really close to what the vendor found, and as low as 0.55, which is basically almost no better than guessing. And whether the model was useful at a given place had a lot to do with its sepsis incidence, but also the complexity of its patients. So the more complex patients that they saw, the lower the C-statistic or area under the curve. The lesser complex patients that a health system saw, the more likely that you were going to have a higher area under the curve or C-statistic. And I think one thing we also found as part of this is that if you were to plot the original Michigan evaluation against this 9 hospital evaluation, it's that orange dot right in the middle there. So Michigan, wasn't really an outlier. If anything, it was kind of along where you would expect the average to be, recognizing that, there's going to be differences in heterogeneity across these health systems. So here we identified, a transportability issue, again, a reproducibility issue, and a transparency issue, even around what we had available to us and trying to make the best decisions that we could. So the reason I keep pointing to the transparency issue is that even though we had what we thought was relatively complete information and it had some discussions with Epic around, the model itself and what information is going into the model, one thing we found out after our paper came out, which we actually didn't know beforehand because it was nowhere to be found in the model brief, was that one of the key factors being considered by the Epic sepsis model to drive its prediction was whether the doctor had already ordered antibiotics. So, I came to find later that, antibiotics are a predictor in the model, but not only were they a single predictor, several of the 80 predictors in this model were actually broad spectrum antibiotics. And so essentially what was happening, at least in some proportion of the patients, was that they were developing signs and symptoms of sepsis, like fever, tachycardia, low blood pressure. The clinician was recognizing that they had sepsis, starting broad spectrum antibiotics, and that was triggering the model to generate an alert to basically tell the provider to start antibiotics. And so if you evaluate this model in kind of a way that doesn't consider this timing of antibiotics and the fact that antibiotics are driving some of the prediction, then you could come to the conclusion that the model does really, really, really well, when in fact some of that performance was being driven by the clinical recognition of sepsis itself. So had we known this ahead of time, I don't know that we would have necessarily done the depth of evaluation that we did, because I think we were really genuinely puzzled in trying to figure this out. But I think that ultimately is what explained that big discrepancy we saw between the model's ability to predict sepsis right before its onset versus in the 3 hours after its onset. A lot of that was being driven by, the timing of antibiotics and clinical recognition being baked into the actual model itself. I'll skip over this other example around acute kidney injury just so we can keep moving. But just to say, this is not unique to Epic or any other specific company. This is a really prevalent issue. These issues around models are really prevalent. They even affect models like this one from DeepMind, where they published a model predicting acute kidney injury, where they said, we'd love for you to go ahead and evaluate this model and to try to independently look at it and use it to improve outcomes. But the actual model itself was not available. So we ended up reproducing a lot of that evaluation from scratch using some funding we had from the VA. And we basically found that, there were some very minor reproducibility issues related primarily to some data elements we had to leave out, but there were major transportability issues. This same model at one VA looks terrible, at another VA hospital looks amazing. And each of these dots here represents one of the over 100 VA hospitals at which we evaluate this model. One thing I think that's underappreciated is that, there's this fundamental theorem in biomedical informatics that a person plus a computer will arrive at a better decision than a person alone. And I think that's generally true, and that's why it's so widely accepted and widely affirmed in the biomedical informatics community. However, there is definitely some recent literature in the space of AI that shows that if a model produces a bad recommendation, clinicians are actually still susceptible to believing it and ending up with a recommendation from the clinician that is actually worse than if they had not been exposed to that AI algorithm at all. So I think one of the ways, there's lots of ways you can try to get at that notion. One of the most direct ways I've seen is this idea of net benefit, where you actually try to figure out what is the relative harm for a false positive intervening on someone who's turns out to be a false positive versus the benefits of intervening on someone who turns out to be a true positive, and calculating the observed model performance in light of that trade-off and trying to figure out, is using a model actually potentially worse than using no model at all? And so if you do this math and you've got a set of value judgments around this cost benefit ratio, you can end up with a negative net benefit, which tells you that if you were to use this model, you'd end up causing more harm than good. And so this is something that I think we need to pay more attention to. And even though net benefit is recommended by the tripod guidelines as something that should be commonly reported in model evaluations, it's very underutilized and often not reported because of this piece where we have to actually go out and ask some questions to figure out what is kind of a reasonable cost benefit ratio for what it is that we're trying to intervene on. The last model related thing I'll just touch on before we move on to some of the implementation oriented issues are this idea of predicting non-modifiable risk. So let's say we're trying to reduce readmissions and you look at the history of the literature in this space. Well, 9 times out of 10, what people do is when we're trying to reduce readmissions, we try to predict the risk of a patient being readmitted. And then if we have an intervention that we can offer, we try to offer that intervention to the highest risk patients on that list. It turns out when we do that, though, that we often discover that the people at highest risk of readmission often have non-modifiable risk. So what people then do is to say, we don't want to identify the highest risk patients. We want to identify the rising risk patients. And rising risk is a misnomer because it's not that they're rising in their risk in any way. It's just the next set of high risk patients. And inevitably, some of the patients in that bucket will also have mostly non-modifiable factors, whereas some will have modifiable factors. But the idea is the further down the list you go, the more you're likely to run into people who may have some real modifiable risk there. So there are more recent methods in the space of causal AI or causal machine learning, causal inference, that are algorithms that can predict individualized treatment effects, the chance that you could, for example, avoid a readmission if you were to intervene. To be able to build those kinds of models, you at the very minimum need some historic data where you've intervened on a set of people and you can see whether that intervention was successful or not. But more and more, we actually have access to that kind of data. And so I think one of the shifts we're seeing is a shift away from simply, focusing interventions on risk and also thinking about the role that modifiable risk plays in trying to intervene on people who may have then, be able to actually change the course of their outcome. Okay, so we talked about some of the model-related reasons why, AI implementations fail. Now I'll focus on just some of the actual workflow issues that come up that lead to interventions to fail. And I think broadly the categories are lack of efficacy, the wrong end users, increased workload, just a cultural lack of readiness for change, and then resource constraints. And I'll give some examples from our work in some of these issues that I'm sure you're also familiar with and have faced. So one learning I had early in my career was that just because you have a good model doesn't mean that when you use that model as part of a workflow that you'll actually improve anything. So on the left, I'm showing you here this AMIA paper that we had with one of my PhD students, Elliot Brannon, where we built a model that could predict the risk of patients coming to the ER at a population level across 3 different counties in Michigan, where we had data from 2 or 3 different health systems all combined together so that we could figure out, a pretty broad encashment area that what the ER usage was. And we were able to figure out that, hey, if we're just predicting the number of ER visits, we can do that relatively accurately within less than one ER visit across the population, recognizing that most people in the population have 0 ER visits, and that's partly responsible for why we can predict it so accurately. However, now let's say we decide we're going to intervene on people at the highest risk and assign them some kind of coordinated case management where they have a caseworker specifically calling them, checking in on them, coordinating with the other social service agencies in the region, and making sure that they get the kind of social support that they need to stay out of the ER for the ones that have social issues driving that, or homelessness, or whatever the issues might be. We have kind of agencies that can help. We put this in place linked to an intervention and studied it using a randomized control trial. And we found that, this community case management intervention was not associated with reduced utilization. Not the first paper to find this, but one of several papers, I think, by colleagues around the country that have done this kind of a thing and found it not to work. So why didn't this work? Well, there's probably a lot of reasons, but I would say one of the big reasons is that if you pick up the phone and call someone, they often don't pick up if they don't recognize the number. It's a really basic human thing. And even though we tried to have the phone calls originate from one of the agencies who that person was already familiar with, so that they'd be more likely to pick up the phone, the reality was that a substantial part of the participants who we targeted through this program never picked up the phone. And so, this kind of a strategy that was model driven, even though in principle was targeting the highest risk patients, it turned out we actually couldn't do much to change their outcomes because we couldn't reach them in a reliable way, despite having access to their phone number from a variety of different sources. I think workload is another one that is starting to be more and more appreciated. But I think historically has been something that's been hard to quantify. So what I'm showing you here is the proportion of patients generating sepsis alerts per day across 24 different hospitals in 4 health systems. Now, most of these hospitals weren't actually generating alerts. They were running these models silently. And so for those hospitals, what we did is we assumed a specific alerting threshold, and we assumed that you would never generate more than 1 alert per day. And so we tried to back calculate the proportion of patients that would have generated an alert if all of them had been using the same kind of alerting strategy. And we looked at the proportion of patients generating an alert before the onset of COVID and in the 3 to 4 weeks subsequent to the first case of COVID that health system had seen. So indexed to COVID is that 0 line. And what we found was that in the 3 weeks after COVID, the proportion of patients generating alerts went up. And it didn't go up at every hospital. Some of them you can see, kind of it's relatively flat. But at a number of hospitals, it went up, and the average number of alerts across all 24 hospitals was substantially higher, I think in the 20+% range, whereas previously it had been below 10% of patients generating alert per day. This was happening on the background of many fewer patients actually hospitalized because of all the canceled elective surgeries. So with that gray shaded area that I'm showing you on the back here is essentially the number of hospitalized patients across all 24 hospitals. So fewer total patients, many more of them generating alerts. And while that in itself isn't surprising, what was surprising, at least to me, was that the total number of alerts was actually higher in the post-COVID period than it was pre-COVID, despite the fact that we had fewer patients hospitalized. So there was this notion that even though the hospital parking lots were empty, what's actually happening in the hospital seemed a lot busier even during that time in the handful of few weeks afterwards. And at Michigan, we actually ended up pausing the alerts 3 weeks after our first case of COVID, which is that orange line. And I think we were curious, was that an experience unique to us or kind of spread across other health systems too? And what this showed us was that this was a real workload issue. We ended up shutting it off because the nurses were complaining that I don't need an alert to tell me that my patients have COVID. All my patients have COVID. So can we kind of stop alerting for sepsis? And indeed, when we talked to other health systems around the country, they had a very similar experience. And even though some of them didn't have to shut off any alerting because they didn't have the alerting on in the first place. So workload, I think, can become an issue, and especially as we build more and more interruptive systems for different related things like sepsis, inpatient deterioration, this becomes a bigger and bigger issue that can essentially compound and lead to alert fatigue. Readiness for change, I think, is a really important thing to think about. The current state when I was at Michigan was that nurses screened all patients for falls. And, there was some interest expressed around using AI to try to actually drive smarter, screening processes or smarter fall prevention strategies among our patient population in the hospital. But when we really asked around, we try to figure out what would the future look like if we were to actually use AI to drive fall detection, what it would have looked like, at least if you're using AI that's purely looking at tabular health data and not using things like cameras where you can detect falls in much more real time. The main thing we would have changed is our screening strategy. And probably since we were screening all patients anyway, we probably would have said, let's not screen some of the low risk patients because that's how we were going to better allocate our resources. But it turned out, at least at the time that I was at Michigan, this was not something that there was an appetite to really do. So there's nothing wrong with that, but just to say that, there was a recognition that, well, we want to continue to screen everyone. And if you want to continue to screen everyone, then it's really hard to know what a model would add to the kind of universal screening strategy unless you're willing to reallocate how you spend your time in screening to potentially, recognizing that you've got limited resources and you want to free up some people to be able to do other tasks. So that relates closely to the last concept that I want to highlight, which is resource constraints. And this will, I think, bring together the process of how we evaluate models from how we implement them. Let's say we have a model we're building that predicts someone's risk of going to the ICU when they're in the hospital. When we evaluate that model, we will consider all of the predicted yeses. Let's say we're applying some threshold to the probabilities and turning every probability that's above a risk of going to the ICU of 20% into a yes. So when we evaluate this model, we consider all the yeses and we consider all the nos, and we report out things like sensitivity, specificity, positive and negative predictive value. But let's say in reality, you only on average have 3 ICU beds open per day. Even though your model on paper does really well, in reality, 3 of those yeses would turn into nos if you only had 3 beds available. And so when we're thinking about deploying and implementing AI models, we also should be thinking about how we should bake in the actual real world constraints we have into the actual evaluation process. So that, if a model identifies, 200, 300 high-risk patients, well, can we even intervene on 200, 300 patients. And if we can't, we probably want to consider the kind of realized performance separately from, the kind of optimal performance if we had infinite resources. So the last thing I'll touch on before I wrap up is just, what are some strategies people are using to make AI better and safer? What's kind of happening in this space? So I think one of the strategies is, if you're at a health system, is just having a set of model cards that tell you what are the different AI tools that we have available, who is the target audience or user for those, who is the clinical owner, and where is that information being filed by those tools, so that we have the ability to look at them, evaluate them, and potentially turn them off or disable them if they're not working. So this is a snapshot of kind of an in-progress set of model cards during my time at Michigan, where I was leading the AI governance work in the form of the Clinical Intelligence Committee at Michigan. I think if you've got active governance, you have an ability to contribute not just locally, but I think also to peer institutions and working with colleagues, and also I think at a national level. And so one thing I realized as we were doing really just an in-house evaluation of our sepsis algorithm and working with colleagues, is that this was a problem not only that we were experiencing, but some of our colleagues were also finding very similar findings. And by putting these out in the public space in the form of peer-reviewed research, I think created some pressure on Epic to actually go ahead and make some big changes to its algorithm. And so right now they're in the process of rolling out a completely different sepsis algorithm, and they've gone, to their credit, made a lot of positive changes that I think make this algorithm a lot more believable, at least from what's being considered by the algorithm and how they're now doing localization at each institution, rather than having kind of one global model that's in use across the country. Interestingly, I think there's an opportunity to shape some of the discussion at a federal or even at an international level. And so in the US, the FDA has since decided that sepsis algorithms are considered regulable as medical devices. The Epic sepsis model to this day has not been FDA cleared because it's not 100% clear that they fall into the scope of the FDA in terms of, as a company, they're an electronic health record vendor. But that said, I think there is an emerging interest, I know both in the US and in Canada, around governing and regulating AI tools to some degree, to make sure that high quality tools are generally the ones that are on the market, and there's some ability to compare one tool to another. There are lots of opportunities, especially in the US, but I know in Canada as well, to provide public comment. Because in the US, there was this recent executive order that essentially charged every federal agency to put together, a chief AI officer and, kind of an AI agenda. And so a lot of opportunities for folks who are students, academics, others, to really put forward your thinking around what this should look like and contribute to that conversation at a national and international level. And so one of the things that we had responded to was a call from the Department of Health and Human Services around, some thinking around algorithmic transparency. And what we really advocated for is that there really needs to be less of this, kind of confidential proprietary business when it comes to basic facts about algorithms. And we really need to put more of that kind of information into the public domain, so that members of the public can have some sense of the sorts of AI tools being used in healthcare, and at the very least, be able to comment on the ingredients of those algorithms, even if the recipes are kept kind of confidential and proprietary. There's a lot of efforts happening in the academic space to, continue to refine the reporting guidelines that academics use, and that hopefully industry folks will also adopt. There's the Tripod AI guideline, which is, I think, close to coming out. It's a modification of the Tripod guideline with a focus on also including AI-based tools. And there's a version of the ProBAS guidelines, which are a way of assessing the risk of bias of algorithms that are currently in development, that hopefully will also be coming out soon. And I think, the last thing I'll highlight is we can't do this alone. And I think no matter what anyone's title is or what your role is at your institution, there is a really important role to partnering with others. And so 2 examples of some of the larger partnerships at the US level are the Coalition for Health AI and the Health AI Partnership. And I think these are the sorts of things I've participated in the past and which I'll be continuing to partner with in the future. But I've learned a lot from peers in this space doing this kind of work, learned from both their failures and their successes. And I think this is a natural thing that implementing AI is a socio-technical problem. So it requires, there's lessons to be learned from really all parts of the science and operations side of things as we try to implement AI-based workflows in clinical practice. So I'll stop there and we'll just thank you for your attention and look forward to chatting.
All right. Round of applause. What an incredible talk and super insightful. I think what makes it unique is that these are really like real world experiences that you've had in either deployments, procurements, and the evaluation of machine learning models. And I think that adds a real, genuine, unique flavor to the work you've done. So thank you for that and congrats on being able to share all those great lessons. There's a lot of different questions coming in, many compliments as well, which is awesome. I'm going to kind of merge a few questions together and almost combine it with one for myself as well. One of the bits that you talked about was around like understanding the impact of false positives, true positives, and literally like almost like a mathematical approach or a formula type approach to quantifying the impact of a model, understanding that maybe a model will have a net negative impact potentially when you do that computation. And so I'm curious on what your thoughts are around how you come up with those calculations and those weights, right? And almost to make a plug, not that I want to lead your answer, but a plug to understanding that working on AI and machine learning projects isn't just like a technical task where you're coding, right? This, in order for you to generate this understanding of impact of false positives and false negatives, you would really be engaging clinicians who can bridge that gap between the impact on the ground and the actual technical solutions that are being built and proposed. And I was curious if you could speak a little bit more about that.
Yeah, thanks for that question. So it is tricky who you engage, but certainly you can engage clinicians, certainly you can engage patients. And I would say who you engage depends really on how severe the harms are and who the harms are to. And so if you're talking mostly about alerts, well, oftentimes, the harms aren't so direct to patients. It's more that you're going to overburden someone with alerts, and the alert fatigue is the actual harm. And so that's the thing you would look at. I'll give an example of just a really quick example of how actually this is done. And I'll point to a paper by, not by me, but by others that have tried to look at this. So let's say you're trying to use an AI algorithm to decide whether someone has, breast cancer. That's reading, mammogram or some other kind of test. And if you have a false positive on a AI test, what ends up happening is you would send someone to get a breast biopsy. And the harm that you would cause there with that false positive is the worry and concern that that person has that they have a potential diagnosis of breast cancer, and also the potential harms of the actual procedure of getting the breast biopsy itself. Now, what is the harm of a false negative there? The harm of a false negative there is that someone is walking around thinking they don't have breast cancer when in fact they do, and potentially their next exam or follow-up isn't for another year, at which point the breast cancer could have spread. If you ask women, and I think I read a study where they actually asked women, what is the relative cost of both of these things? There's a whole decision analysis literature separate from machine learning that looks at this kind of stuff. I want to say it was something around 20 to 1. And so essentially, you'd be willing to accept 20 false positives for every 1 false negative was roughly what it was. Now, no individual clinician or individual patient will, even on the 2 different days, feel exactly the same way, but it can give you some back of the envelope, idea for how good a model needs to be able to be better than not having a model at all. So in this kind of an algorithm, what does it mean for that 20 to 1? It means that you would probably want to intervene when someone's risk is greater than 5% or 1/20. And you would look at the performance of the algorithm at that threshold. So that's a way to both set a threshold, but also to look at, is the harm of the model greater than the benefit of the model by looking at net benefit? That's not the only way to look at it, and people have proposed all kinds of other things, but I think that's one that's grounded in an actual question that people care about. And the last thing I'll just say about that is two identical algorithms that produce identical probabilities used for two different purposes, one of them can be useful and one of them can be useless. So the same algorithm producing the same probabilities, using it to drive whether you take someone to surgery versus whether you prescribe a relatively innocuous medication, you can say that one of those is going to be completely useless versus the other. And the only way you can really justify that is that you must have a different, in your back of your mind, cost benefit for the harm of a false positive taking someone to surgery unnecessarily versus the harm of a false positive for prescribing a medication that someone turned out not to need.
Totally. And one of the things that I love that you said was around that engagement with the end user, but most importantly, the patients themselves, right? So not necessarily making value judgments on what we assume patients would understand is the cost benefit to them, but really engaging patients to quantify that. And I'm curious then how you foresee linking that idea and that understanding of what your end users or patients may want within the transparency message that you had you'd sort of posted before, when you talked about there's a 20-to-1, ratio between false positives, true positives, et cetera. Like, do you feel that then that we should be then really being super transparent? Like, we're going to use this model. Here's sort of the stats on how the model works for your population, et cetera. Like, is that a vision that you plan to move forward with and implement?
So I think, in my mind, the information provided by the vendor around how well the model performs, at that level, in my personal opinion, that should just be in the public domain. That's not leaking any private information about the model that would, I think, provide competitive disadvantage. In my mind, that's the fact that, hey, if we're going to use this to derive a decision making about someone's health, or that might indirectly affect someone's health, it should be in the public domain. That's not to say that the patients reading that will necessarily need to understand it. It's not written for patients, but I think it's written for members of the public who will understand it and may be able to, comment on the appropriateness of it. The thing I feel really strongly about is, there's a lot of focus in AI around explainability and the actual recipe. But how can we talk about recipes if we don't know the ingredients? And so my feeling is, at least make the ingredients available to the public, and then keep the recipe secret to yourselves, just like we let everyone else do for all kinds of other things. But at least the ingredients need to be in the public domain so that we can decide, is that some information that we're comfortable to use to guide decision making or not? And there have been so many examples now recently where, if I knew that antibiotics were an ingredient in this model, I would have looked at it very differently. Or for a no-show model, if I knew that religion was an ingredient in a publicly available, and widely used no-show model, I probably would have made a different decision around, whether we would use that model or not.
Yeah, I 100% agree with you. And I sit both on like the academic side, the procurement side, and the industry side. And I think what you're saying, regardless of where you sit on this AI journey, what you said should be the goal for sure. Now, you mentioned the antibiotics and then the EPIC sepsis model. So I'll try to merge these other two questions together. One was around when you were comparing the AU ROCs between what EPIC was saying was the 0.88 and you had 0.6 something, 0.63 maybe. Were the two calculations using the same outcome, right? Yep. And the same definitions of sepsis? That was part of the issue. That was part of the point you were trying to make.
Yeah, that was, I think, part of the reason there was a difference is both how the outcome was defined and assessed by the vendor at that time was a really non-standard definition. And even though I would argue ours wasn't substantially better in any way, ours was the definition that our hospital sepsis committee was using operationally. And so when we found this discrepancy around why is this model on paper really good and we're not finding it clinically useful in the 2 or 3 units where we were piloting it, we said, let's independently look at its ability to predict the actual outcome our committee uses. We followed it up with a more standard definition, which is the sepsis 3 consensus definition, when we looked at the WashU data set across their 9 hospitals in their network. And actually, in the latest update to the EPIC sepsis model, they also now use the consensus sepsis 3 definition. But even there, if you're deep in the weeds, there's all kinds of things you have to worry about that could affect what you consider to be not just whether someone has sepsis, but the actual time zero for when the sepsis definition was met.
Yeah, totally. No, that sounds great. And it is a real like trigger for anyone who is thinking about like on the procurement side of machine learning models, really making sure you understand what the model is doing and what the definition of a label and success is, which sometimes could be over the head of folks potentially procuring a machine learning tool. The idea, so that notion actually, which kind of hits on around AI literacy, sort of leads me to another question here, which is around how should we be thinking about evolving academic programs and professional development in healthcare and health leadership to be ready for AI?
Yeah, so that's a great question. I would go back to the approach that how we've approached even like basic statistical literacy. And what I would say is two things are true. We probably do need to educate clinicians on basic statistics, but on the other hand, we don't necessarily want clinicians to be so confident in their skills that they're not asking for help and partnering with folks who actually really understand the domain really well. So I would say it's similar in machine learning AI. There are curricula that I've contributed to that are designed around explaining basic concepts to clinicians so that when they read a paper, they have a general sense of what is happening. But at the same token, I don't think that's a replacement for working closely with domain experts who understand, more methodologically about ways in which, information can be kind of massaged a little bit to get better or worse AUCs or things like that, where a clinician might miss that. But in all my comments, I think what you've seen is you also have to have someone who really deeply understands the actual the data and the clinical side of things. And usually the person who understands the data the best is actually the clinical expert in that area. So I'm not a sepsis expert. I've worked and been really thankful to be able to run ideas past people who really understand how sepsis is calculated, determined, and the actual process of treating sepsis, so that when we do an evaluation, it's really a best case evaluation based on the information we have from our domain experts and partnering with people who understand the actual math to say, are we really looking at this the right way?
Yep. No, that's great. So we've got about 5 minutes left, so I'm going to rapid fire through a few questions. There's some really amazing questions here, and more than usual. So again, speaks to the engagement, Dr. Singh, you're able to generate, which is great. One question here is around, Canada has a very decentralized system. So our largest hospital networks are 2 to 3 sites. Our primary care practices are highly decentralized with very little coordination across sites. Have you given any thought to what safe AI deployment looks like at the edges of the healthcare system, where there are fewer resources to support local validation, deployment, and monitoring, et cetera?
Yeah, that's a great question. We've published on this idea of collaborative governance. And there is a paper I can track down that we wrote, which really talks about this issue of some centers are very well resourced to do this kind of work. Some centers are not. Even within a system, you might have, multiple hospitals or multiple clinics where some of the clinics or hospitals are much better suited to look at this than others. And so I think the way that we can potentially get to this is some form of collaborative governance where the larger centers are able to provide some level of services to centers that don't have the resources. But I think accountability always has to sit locally. So I think that, if you're going to use AI in your clinical workflow as, let's say, a primary care physician at a solo practice or at a practice with a handful of clinicians, you should be accountable to however you're using it. So if you're using it to double book patients, you're using it to do things like that's, you need to understand how it's being used, even if you don't understand the math behind it. In the same way that if you were, deciding to whether to start someone on aspirin or on warfarin for atrial fibrillation, you would turn to a risk tool and, calculate some math and figure out, is this person's risk above the threshold at which I would normally recommend that they start something like warfarin. So I think it's not that different, in terms of the type of literacy involved, but, so a lot of my emphasis is always on removing the magic from it and saying, yeah, even if the math is complicated, how we were using it, is often has the same implications as other sorts of tools we're really familiar with using already.
Yeah, no, that makes a lot of sense. There's another question here around, let me just find it. So there's been a number of AI reporting guidelines, and you presented a few actually, that have just come up over the years, and yet adoption remains relatively poor with utilization of these guidelines. So the question is like, what can we do about this? And I'm just going to add on to it, like, do you think that there is a role for the regulator to play in regulating how much information or the minimum bar of information that needs to be made public for when these AI models go to market? So similar to like what you would do for like a pharmaceutical drug, right? There's a clear pathway of what needs to be disclosed. Should AI adopt a similar type of framework?
Yeah, it's a great question. I think the reason it's complicated is that there is no one agency that oversees all of this, at least in the US. FDA certainly plays a role, but for example, the Epic models are, at least in Epic's view, as I understand it, not necessarily within the scope of the FDA, because they're not out there marketing these models. They're baked into electronic health record software, which falls into the EHR certification process, which falls into the Department of Health and Human Services, as I understand it. So I think, while we had this public comment arguing for basic transparency about basic information about algorithms, I don't think that can really go to any one agency that's doing the regulation. I think it has to be something that we kind of adopt at a more uniform level across agencies. So that's why I always advocate for transparency, because I say, before we can talk about math, we need to know what are we adding up. And
Yeah.
so, but yeah, it'd be great that if FDA played that role. But realistically, there are many, many tools in use right now that, the majority of tools that we use in healthcare AI are not things that are necessarily even in the scope of the FDA.
Yep. So I wonder then, like, I mean, you thinking about the role that you'll be taking on as the chief AI health officer at this new institution in San Diego, and what role folks like you who will be procuring or advising on procurement and implementation of tools, then sort of have to say, look, like we set a bar, like we need to know this before we procure it. And the market may, through even AI literacy amongst leaders who shepherd in the adoption of AI, can play a pretty powerful role in setting a bar themselves, even if not regulated, to say, if you're an industry and you're marketing, we need to know this, this, and this, or else it's potentially a no-go. Do you know what I mean? Like, I think there is a post-market role for folks like yourself who may influence that and not necessarily the FDA alone.
Yeah, it's certainly a question I ask every company is this information public? Because I think it is something that I'm trying broadly to push for. I think the biggest thing I'll be doing right now is, doing some of the work of just shepherding and building those model cards for what's currently in use, how are we using it.
Yeah.
And I think some of what I'm hoping to bring to UC San Diego Health is really, setting up infrastructure that gives us the option to build versus buy. And I think right now, like every place, there are some things that have been built locally, something that have been bought. But I want to, I think, have a better strategy around that. And certainly, I think if we have the infrastructure to build and the options to buy are really non-transparent, that we're not sure that we can put our faith in, we are going to make decisions, I think, that will consider that as part of a broader set of things. But recognizing that it's not just the models, it's the tools that companies have built to make those models accessible. And a place where procurement often plays a large role is, yeah, we could build that model in a week, but we couldn't build the tooling and workflow pieces in a week or in a year that a company can provide. So we're looking at the whole picture. I don't think this is the one issue on which things hinge, but it is an important issue to me.
Yeah, that's awesome. Well, we're just a minute above time. I'm sorry for those of you, tons of questions if we weren't able to answer them, but I will take a look through them to see if we can get some answers sent your way. Otherwise, join me in thanking Dr. Singh for spending his hour with us presenting incredible work. So thank you so much. We really appreciate you and look forward to having you come back anytime.
Thank you for your time.